Therapy is often spoken about in reverent and hallowed tones, as though it exists outside ordinary human institutions, insulated from the corruption of power, bias, and self-interest, shrouded by a shield of unquestionability, and to question it can feel almost immoral, like doubting a priest in a confessional or a doctor at a bedside. It has also become a space where people with supremacist dispositions use their having been to therapy as a crutch to denigrate others who haven't seen any reason for it. Phrases like seek therapy are used in tones designed to denigrate, and yet therapy is one of the few spaces where a person is encouraged to lower their defenses completely while being granted the least protection in return. It is a relationship defined by asymmetry. One voice is framed as experience, the other as interpretation. One as raw and uncertain, the other as trained and authoritative. When this imbalance works well, it can be healing. When it doesn't, the harm is subtle, deniable, and often invincible, even to the person being harmed. And that is the central problem with therapy. Not that it feels loudly and obviously, but that it can feel quietly, while still insisting it knows what health looks like. When we fall in the hands of the wrong therapist, we can be diagnosed with problems we never had, blamed for conflicts we never caused, and even advised to remain loyal to people who are out to ruin us. A particularly insidious problem emerges when therapy quietly becomes a system that cannot tolerate being outgrown. In many real-world cases, clients who express a desire to pause or end therapy are not met with curiosity, but reinterpretation. The wish to leave is reframed as avoidance, fear of intimacy, unresolved attachment trauma, or resistance to the work. What would be a legitimate exercise of autonomy is instead folded back into the diagnosis itself. The dynamic is not hypothetical. Former long-term clients routinely describe how stagnation, emotional exhaustion, or even worsening anxiety were explained away as signs that therapy was finally reaching something important. In some cases, individuals remained in weekly sessions for years without measurable improvement, not because they were benefiting, but because the therapeutic narrative made leaving feel dangerous, like abandoning treatment midway through a life-saving procedure. Financial incentives quietly reinforce this pattern. Therapy is typically paid per session, progress is difficult to quantify, and there is no professional penalty for endless continuation. The result is a self-protecting structure, where therapy rarely fails. It merely insists the client hasn't stayed long enough. In this way, a practice meant to restore agency can subtly erode it, teaching people to distrust their own judgment about what is helping them, and to outsource their sense of readiness, completion, and even identity to the very system that profits from their continued uncertainty. Alongside this pressure to persist sits another, quieter problem: the ease with which therapy absorbs theories that are weakly evidenced, unfalsifiable, or simply fashionable, and then treats them as clinical truth. Clients are told they are reenacting attachment wounds, repeating trauma stored in their body, or governed by inner parts that must be negotiated with, often without being told that many of these frameworks rest more on metaphor than on rigorous science. When such ideas help, they are credited with insight. When they fail, the failure is attributed to the client's lack of readiness, resistance, or insufficient trust in the process. Because these theories are elastic and interpretive, they cannot be meaningfully tested within the therapy room. Any outcome can be explained after the fact. A person who improves confirms the model. A person who deteriorates simply reveals deeper issues. Over time, speculation hardens into doctrine, taught to trainees, repeated in self-help culture, and defended, not through evidence, but through anecdote and conviction. What emerges is not a science in the strict sense, but a belief system, one that borrows language of empiricism while operating on faith, insulated from correction by the very vulnerability of the people it is applied to. There is also the rarely examined question of the mental health and personality of the therapist themselves, a topic treated as impolite, even unethical. Despite its obvious relevance, therapy rests on the assumption that those who guide others through psychological terrain are sufficiently self-aware, emotionally stable, and ethically grounded to do so. Yet, the profession offers remarkably little scrutiny, beyond academic qualification and supervision hours. Many therapists are drawn to the field through personal history, unresolved trauma, a need to make sense of their own suffering, or a desire for control dressed as care. A peer-reviewed literature review on the motivations of psychotherapists found that many practitioners are drawn to the field as a result of their own personal struggles and challenges. The wounded healer concept suggests that those who have experienced emotional pain, trauma, or early relational difficulties often enter psychotherapy professions, sometimes consciously, sometimes unconsciously, because of how their own history shaped them. A systematic review found that personal trauma history is common among mental health professionals, with prevalence in studies ranging broadly, example 19 to over 80%. This research also suggests that those with such histories are more likely to experience secondary traumatic stress, linking personal experience with the emotional burden of working in this field. Qualitative research specifically exploring relational and developmental trauma found connections between early life adversity and the motivation to pursue a psychotherapeutic career. These studies argue that unresolved relational wounds can push people toward caregiving roles as a way of attempting to repair or master their own past experiences. This does not disqualify them, but it does matter. When unprocessed issues remain, they can quietly shape interpretations, boundaries, and responses. A therapist's anxiety may manifest as over-pathologizing risk. Their need for validation may show up as subtle dependence. Their ideological rigidity may be mistaken for clinical certainty. Yet, clients are discouraged from noticing this asymmetry, let alone naming it, because the therapist's inner world is treated as irrelevant to the work. In any other intimate high-stakes relationship, such opacity would be alarming. In therapy, it is normalized, leaving those with the most interpretive power the least examined, and the most vulnerable with the burden of adapting to whoever happens to be in the chair across from them. Therapy, despite its stated goal of supporting the vulnerable, can sometimes become complicit in abuse, subtly, quietly, and without overt malice. In case of domestic violence, coercive control, or manipulative relationships, therapists often frame conflict in terms of the client's communication style, emotional regulation, or attachment wounds, while minimizing or normalizing the abusive partner's behavior. You might be overreacting, or have you considered your role in the tension? A common refrains, shifting responsibility onto the victim under the guise of insight and growth. Even when abuse is acknowledged, the therapist's emphasis on empathy, forgiveness, or emotional repair can trap clients in cycles of harm, subtly reinforcing the abuser's power. Real-world studies on intimate partner violence highlight that victims who remain in therapy often report feeling blamed, dismissed, or pressured to maintain the relationship, especially models that prioritize couple work over safety planning. In essence, therapy can unintentionally operate as a mechanism of social compliance, teaching clients to adapt, endure, and rationalize harm rather than resist it, all while preserving the moral authority of the therapist and the supposed neutrality of the therapeutic space. Another insidious aspect of therapy lies in the ease with which ordinary human struggles are reframed as psychological disorders, sometimes without sufficient evidence or scientific grounding. Loneliness becomes depression, grief becomes complicated grief, shyness becomes social anxiety disorder. Normal fluctuations in mood, personality, or coping are recast as pathology, and the client, already vulnerable, internalizes this label as truth. This is not mere abstraction. Studies of DSM expansion show that with each new edition, thresholds for mental illness have broadened, creating diagnostic categories that increasingly encompass behaviors and feelings once considered within the range of normal human experience. In practice, a client seeking guidance on stress at work or sadness after a breakup may leave feeling fundamentally broken, carrying a diagnosis that reshapes how they see themselves. The therapy system, with its authority, language, and repeated reinforcement, can convert ordinary suffering into chronic identity-altering problems. When a theory is untested, the therapist's judgment becomes the default reality, and any personal resistance to the diagnosis is interpreted as denial or lack of insight. In this way, therapy can paradoxically manufacture the very problem it claims to solve, leaving clients more preoccupied with fixing themselves than with engaging meaningfully with the lives they already have. Therapy has a tendency to interpret nearly every difficulty through the lens of trauma, as if past injury alone accounts for who we are and how we act. Struggles with temperament, impulsivity, or anxiety are routinely traced back to some unhealed wound, early neglect, or emotional scar, even when biological, genetic, or neurochemical factors play a central role. This framing can be comforting. It promises explanation, narrative, and the possibility of repair, but it also risks misattribution and oversimplification. A naturally high-strung child becomes reactive due to trauma. A socially withdrawn adult becomes avoidant because of a formative relational rupture. A predisposition toward depression is routinely reframed as an unresolved past. By consistently blaming the past, therapy can obscure the inherent diversity of human nature, inadvertently pathologizing traits that might be within the range of normal variation. Worse, it teaches clients to see themselves as damaged objects to be fixed, rather than complex organisms whose tendency emerge from an interplay of biology, environment, and choice. In doing so, therapy can become less about understanding the self in its full complexity and more about constructing a narrative in which trauma is always the culprit, responsibility is always internalized, and innate patterns are always suspect. Misdiagnosis is one of therapy's quietest but most consequential failures. In practice, it often occurs not because therapists are careless, but because the very frameworks they use are imperfect, culturally biased, or overextended. Anxiety becomes bipolar disorder, normal grief becomes persistent depressive disorder, childhood restlessness becomes ADHD. Each label carries authority, reshaping how the client interprets themselves and how others interpret them. Once a diagnosis is attached, it is rarely questioned. Therapy, by design, encourages trust in the process and the professional, making doubt feel like denial or resistance. The consequences are profound. A misdiagnosed client may undergo unnecessary medication, experience prolonged self-stigmatization, or internalize a sense of defectiveness where none exists. Families, schools, and workplaces may respond to the diagnosis rather than the person, creating feedback loops that reinforce the truth of a label that was never accurate. In this way, misdiagnosis does more than fail to help. It creates new problems, convincing ordinary human complexity that it is a disorder in need of constant correction. Therapy often presents itself as a universal solution, as if there were a single map that could guide every mind through every kind of suffering. Cognitive behavioral techniques, psychodynamic frameworks, or mindfulness practices are offered as broadly effective, while the vast majority of human personality, culture, and circumstance is quietly compressed into checklists and manuals. The result is a one-size-fits-all approach that mistakes standardization for efficacy. A method that works for one client may fail or even harm another, yet the therapy system often lacks mechanisms to recognize or correct these mismatches. Cultural norms, neurodivergence, socioeconomic context, and individual temperament are frequently treated as secondary variables. If considered at all, clients are asked to adapt themselves to the model, rather than the model being adapted to them. Over time, therapy can shift from a tool of insight to a template of conformity, teaching people not how to navigate their unique lives, but how to fit the expectations of a framework designed for convenience, not truth. Taken together, the problems within therapy form a pattern that is as subtle as it is pervasive. Vulnerable people enter seeking guidance, only to find themselves caught in a system that can keep them dependent, misdiagnose their experience, pathologize normal variation, and flatten the richness of human nature into standardized categories. Unscientific theories addressed as insight, the therapist's own unresolved issues remain largely invincible, and structural biases, cultural, financial, or institutional, silently shape every interpretation. Therapy, in theory, is a sanctuary, can become a place where autonomy is deferred, ordinary suffering is reframed as defect, and the complexity of human experience is reduced to narratives that serve the model rather than the individual. It is not that therapy is inherently harmful, may find relief and clarity, but that the field carries within it a set of dynamics that demand vigilance, skepticism, and humility. Without these, the very system meant to heal can paradoxically constrain, mislead, and even create the problems it claims to resolve. In the end, therapy is a tool whose power is real, but whose limitations are profound, and ignoring those limitations risks turning care into control, insight into prescription, and support into silent complicity.